Welcome to the discussion of the Uworld question ID 4934. The patient is 40 years old. He is male. He is complaining of pain and epigastric burning. I assume that epigastric burning is caused by the irritation to the stomach made by potassium chloride. Potassium chloride is the main culprit in this case for many things, as we will see in the next few slides. I believe that epigastric burning is not related to acid reflux. It's more of stomach irritation. If you have any better explanations, do not hesitate to leave it in the comment section. But this is the furthest I could think about. This pain is the major complaint, and I can analyze it. The site is retrosternal. The onset 2 days ago. Character, it was burning, but in different region, so I cannot say that this burning is related to the pain. It's different, because the burning is in the epigastric region, while this pain is retrosternal. Radiation, he didn't say anything about radiation, whether it's radiating to the back or not. I'm expecting it to be radiating to the back somewhat, because esophageal diseases may cause back pain or even interscapular region in the back. Anyways, he didn't mention anything about it. It's associated with odynophagia, which means pain with swallowing. The severity is very severe. There is no associations like blood in stool, melena, vomiting, shortness of breath. Exclusion of shortness of breath might somewhat exclude cardiac and pulmonary causes of this pain. Chest pain, you think about cardiac and pulmonary causes. But since we are speaking about odynophagia, we think more about some GI causes, gastrointestinal causes. By examination, there's normal vitals and normal physical findings except a murmur. This murmur is a hollow systolic murmur at the apex, which means a murmur of mitral regurg. It's most probably a dilated heart. As we will see in the past medical history of the patient, there is a cardiomyopathy treated by these drugs. So this is most probably is going to be a dilated cardiomyopathy or a systolic dysfunction. In systolic dysfunction, we treat the patient with some drugs. Some of them have better mortality benefit, some don't, as we will see. Lisinopril, it's an ACE inhibitor. Carvedilol is a beta blocker. Spironolactone is a potassium-sparing diuretic. 3 of them are being used. Spironolactone in particular is used in advanced stages of congestive heart failure. And furosamide is used to control symptoms only, along with the digoxin. So maybe furosamide is added recently with potassium chloride to control symptoms. But the first 3 are the ones with mortality benefits. And what makes me think that potassium chloride might be added recently, because it's not typical to use in treatment of cardiomyopathy, but it might be used to treat a complication of furosamide. One of the complications of furosamide is going to be hypokalemia. We treat hypokalemia especially with alkalosis with potassium chloride. Another thing to note that he's taking too much drugs. So if he started taking drugs in sequences, then when he comes to the last drug, if it was potassium chloride, for instance, he might not drink enough water for it. He might be already full of water, so he takes less water. And we will see in the next few slides that we need to drink a lot of water with potassium chloride. So we made an endoscopy. Why did we make an endoscopy? First, let's just pause here for a second. We assume that there was a stool analysis made. How did we know that? Because he excluded melena and blood and stool in the case. Anyways, endoscopy was done. Why was it indicated? It was indicated due to severe odynophagia and pill-induced esophagitis, which can be clinically diagnosed by odynophagia and certain drug intake, history of drug intake, we can make a decision to use endoscope if there are severe symptoms. Another thing, odynophagia is an alarming symptom in dyspepsia that indicate usage of endoscope. What we see using endoscope is a circumferential deep ulcers with surrounding normal mucosa. This is pathognomonic for pill-induced esophagitis. Ulcers are in the middle third. Why was that? I searched for this and it came out to be related to the aortic arch compressing it or dilated left atrium. So this is the place where there is some sort of stagnation, so the drug might stay here for some while, it's gonna cause irritation and all of that. And dilated left atrium in this case in particular is prominent since there is mitral regurg. I'm expecting there might be dilated left atrium, increasing the chance of this happening. Drugs that do make the patient more susceptible for pill-induced esophagitis or culprit drugs include tetracycline. This is personally happening with me. It happened personally with me, tetracycline. I'm not saying that esophagitis happened with me. Tetracycline is very heavy. I took it once. It's extremely heavy. You have to know that. Take it in the upright position and drink enough water. Tetracycline. Potassium chloride, as in this case. Iron supplementation is very common for anemic patients, so don't forget to tell them that, to drink enough water and take it in upright position. Bisphosphonates as well, non-steroidal as well can do this pill-induced esophagitis. So you advise the patient to take drug in upright position with enough water intake. So if he's taking so many drugs, like in this patient, because he has heart failure, heart problem, then he might be taking a lot of water that he just takes the last drug, like potassium chloride, for instance, with not enough water. So this might induce this esophagitis. Keep that in mind. And that concludes the discussion, my personal discussion of this question. If you have any questions, do not hesitate to leave it in the comment section. If you have any additions, you're welcome. Thank you and good luck.